Hello my friends, welcome back to Cardiac Academy. In the last few videos, we've been talking about different types of arrhythmias and everything associated with them. So this video, we're gonna talk about blocks, more specifically, AV blocks. This is an important topic, so let's get started. All right, let's start talking about conduction blocks. So in conduction blocks, we have three different locations, okay? We have a block at the level of the SA node, which is called a sinus block. And in this case, the sinus node is firing and it suddenly stops. So we have seen this before, and we said that when the sinus node stops firing, then usually we have an escape rhythm or an escape beat that comes to rescue the day, okay? So a sinus block just means that it's a pause, and we usually get an escape rhythm or beat to continue these depolarizations, okay? Next, we have the AV blocks, and the AV blocks can happen at different locations. It could happen just between the SA node and the AV node. We can have at the level of the AV node, and we can also see it happening within the His-Purkinje system. And we finally have the bundle branch block, okay? So remember that we have two bundles. We have the right bundle and we have the left bundle. The left bundle further subdivides into fascicles, okay? We have an anterior fascicle and a posterior fascicle, okay? Which are also called, when they're blocked, they're also called hemiblocks, okay? So we're gonna go over all of these, but let's start talking about the AV node or AV blocks, okay? So AV blocks come in three different types. We have first degree AV block, second degree AV block, and third degree AV block, okay? Remember when we read EKGs following our mnemonic, erratic, the AV blocks are gonna fall under rhythm, okay? Remember that in rhythm, we assess for 5 questions. The first question is, are there any P waves? After that, is there a P wave for every QRS? And you're gonna see that in that second question, we're gonna see third degree AV blocks, because remember that in third degree AV blocks, there are gonna be more P waves than QRSs. After that, we ask ourselves, is the QRS narrow or wide? And that's also gonna help us identify when there is idioventricular escape rhythm or junctional escape rhythm, which we can see in third degree AV blocks. And then we ask, is the PR interval prolonged? And in first degree AV blocks, we're gonna see that the PR interval is in fact prolonged. And that's also gonna be true for first and third degree AV blocks. So when we assess for AV blocks or any type of block, rhythm is gonna be when you do so, okay? Remember, erratic, the first E is for EKG, first R is for rate, second R is for rhythm, and on the rhythm, we ask these questions, and on the rhythm is where we're gonna find blocks, okay? Very good, so let's continue. So first degree AV block, that's gonna be the first one we're gonna discuss. So just like we said, in first degree AV block, the key is that the PR interval is gonna be prolonged. So remember that a normal PR interval should not measure more than 200 milliseconds, which is the same as 0.2 seconds, which is the same as 5 small box or 1 big box, okay? Remember that each small box is gonna measure 0.04 seconds. And when we add 4 of these small boxes, they're gonna add up to 0.2 seconds, okay? Which is the same as 200 milliseconds, okay? So the PR interval should not measure more than a big box or 5 small boxes, okay? And we can see that here. In this first degree AV block, we can see how it's larger than a big box. You can see that here. And we can see that it's the same for all the PR intervals. So it's not changing, it's staying the same. So this is a first degree AV block, okay? So remember that in first degree AV block, what we're seeing is that the time it takes for the depolarization coming from the SA node to reach the AV node is getting prolonged. That's why the PR interval is getting larger, okay? And first degree AV block is extremely common. It does not necessarily mean pathology, but in some occasions it may. For example, if you have someone who has no documented first-degree AV block and is a known IV drug user, and all of a sudden develops a first-degree AV block, then in that specific situation, it might mean that you're having vegetations growing in that valve, which is causing problems in the conduction system. So in that case, if you have someone who has no first-degree AV block and then develops a first-degree AV block, and the clinical picture dictates that there might be a problem, so in that specific situation, yes, then a first-degree AV block might be pathological. But in most time, it's not, okay? Very good. All right, let's shift into second-degree AV block. So second-degree AV block can be divided in Mobitz type 1 and Mobitz type 2. So Mobitz type 1 is also known as Wenckebach block. And the way we're gonna differentiate type 1 versus type 2 is by looking at the PR interval and looking to see whether the PR interval is prolonging, okay? Let me show you how. So in this first example, we can see how we have P waves here. The first PR interval is normal, and the second PR interval prolongs, and then the third one prolongs even further until we have a P wave here without a QRS. So we can see a QRS was dropped, okay? So we can count the number of P waves, and we see we have 1, 2, 3, and 4 P waves. And then we count the number of QRSs, and we see 1, 2, 3, and then the one that dropped. So in this case, we have a Mobitz type 1 because the PR interval is prolonging and prolonging until a QRS complex is dropped. We count the number of P waves we see is 4, and the number of QRS is 3. So this is a Mobitz type 1 with a 4 to 3 AV block, okay? Now let's see the second example. So in this second example, again, we look at the PR interval. We look at the P wave right here. We see a P wave, and then we see a P wave. However, we notice that the PR interval is not prolonging. It's just the same in all cycles until one QRS is dropped, okay? And we can do the same. We can count the number of P waves, and we see 1, 2, and 3. So 3 P waves. And then we count the number of QRSs, and we see 1 and 2 before it gets dropped. So we can see that this is a Mobitz type 2 because the PR interval is not prolonging, and it's just the same distance, the same PR interval until a QRS is dropped. So this is a Mobitz type 2 with a 3 to 2 AV block, okay? Very good. Now let's take a look at these other examples. So we do the same thing. We look at the PR interval, and in this first example right here, we can see that the PR interval is not prolonging, it's staying the same, okay? So that alone tells us that this is a Mobitz type 2, because in Mobitz type 1, we would expect that PR interval to be prolonging until that QRS is dropped. So in this case, it's the same interval, and then QRS is dropped. So that's a Mobitz type 2. So let's identify that even further. So we count the number of P waves, and we see 1, 2, and 3 before a QRS is dropped. So 3. And then we count the number of QRSs, 1, 2, and then gets dropped. So this is a Mobitz type 2 with a 3 to 2 AV block. And then the next example, again, PR interval is staying the same, although you will notice that in this case we see a P wave and then a P wave which drops the next QRS. So there's no way for us to really tell whether the PR interval is prolonging, okay? We just noticed that the QRS got dropped after the second P wave. So we don't know whether this is a Mobitz type 1 with a 2 to 1 AV block or a Mobitz type 2 with a 2 to 1 AV block, because there's no way for us to assess whether the PR interval is prolonging, okay? So we just know this is a 2-to-1 block, which could be a Mobitz type 2 versus type 1. Now, an important fact to remember is that AV block of 2-to-1 or above is considered a high degree AV block, and these are more dangerous because they can prolong to a complete heart block, okay? Now, in general, second degree AV blocks, Mobitz type 2, are dangerous and should be assessed for a possible permanent pacemaker. But 2-to-1 AV block is even more dangerous and need also to be evaluated for a pacemaker. All right, very good. So we finally made it to the third degree AV block. So a third degree AV block is also known as a complete heart block. The reason being because the atria and the ventricles are completely independent from each other. So the atria in this case is not driving the heart rate, and for this reason we develop an escape rhythm, okay? So if you don't remember what escape rhythms or escape beats are, please watch our videos on those topics. I'm gonna link that video in the description below to refresh your mind, okay? But just as a quick recap, an escape rhythm occurs when the atria, or the SA node, I should say, fails to drive the heart, okay? So in our heart, we have different locations, each of which have their own intrinsic pacemakers. So we have the atrial pacemakers, we have the junctional pacemakers at the level of the AV node, and we have the ventricular pacemakers, okay? And the lower we go in the heart, the slower the heart rate will be, okay? So in this case, because there's a complete heart block, then the atria is not driving the heart, so it's either occurring at the level of the AV node or at the level of the ventricle. So it's either a junctional escape rhythm or an idioventricular escape rhythm, okay? So you're gonna see that in third degree AV block, the heart rate is gonna be very slow. That's because the heart rate is being driven by an escape rhythm. If it happens at the level of the AV node, it's gonna be a junctional escape rhythm, and it's gonna be around 40 to 60 beats per minute. And if it occurs at the level of the ventricle, it's gonna be called an idioventricular escape rhythm. It's gonna have a heart rate of about 30 to 45 beats per minute, okay? All right, let's take a look at this clinical case. So an 80-year-old woman with history of lightheadedness fell and broke her left hip. She was found to have a slow pulse. An EKG was performed. The orthopedic surgeon wants to operate as soon as possible, but the anesthesiologist wants a cardiologist to evaluate the patient first. But it's a Friday afternoon, so you were the best next thing available, okay? So what does the EKG show? Well, let's take a look. All right, so let's start by remembering that we need to be systematic always. So what's our mnemonic? Our mnemonic is erratic. So let's follow our mnemonic, okay? So erratic. Okay, so E stands for EKG, and just to make the mnemonic work, the first R is for rate. So let's calculate the rate. So here we can see it's a very slow heart rate. We have a rhythm strip right here in lead 2. So let's just count the number of QRS and multiply by 6. It's gonna be easier. So we have 1, 2, 3, and 4 multiplied by 6, 24. So 24 beats per minute. It's a very slow heart rate, right? Very bradycardic. And then we go into rhythm. And in rhythm, we have those 5 questions which we keep bringing up, right? So the first question is, are there any P waves? And we look and we see plenty of P waves, right? You see P wave here, another one here, another one here. So yes, there are P waves. Now, is there a P wave for every QRS? Now, that's where the money is. So we see that no, there's much more P waves than QRSs, right? So that alone tells us that this is either Mobitz type 2 or a third degree AV block, because we're seeing much more, or even a type 1, because there's much more P waves than QRSs. But let's continue. Then we say, is this QRS narrow or wide? And we see this is a wide QRS, right? So we can look at the R wave here and the S ends here. So it's more than 120 milliseconds. So that means that we're having possibly an idioventricular escape rhythm, right? Because the heart rate is very slow and we have a prolonged QRS. So we have a lot of P waves that we can see that they're not related or associated with every QRS. So that alone tells us this is a 30-degree AV block with an idioventricular escape rhythm, right? But just to be thorough with everything, so is the PR interval prolonged? Well, P waves have no relationship to the QRS. And those are all the questions. Are there any P waves? Is there a P wave for every QRS? Is the QRS narrow or wide? Is the PR interval prolonged? Oh, and finally, is the rhythm regular or irregular? And this is a regular rhythm, okay? Because the distance between QRS and QRS is the same. So we said we have a third-degree AV block with an idioventricular escape rhythm, okay? But we don't need to specify that, okay? Then comes axis. And for axis, remember that we look at lead 1 and AVF. If lead 1 and lead 2 are both upright, that means that's normal. That's the 2 thumbs up. That's a normal axis. But in this case, we see that the lead 1 is actually negative and lead AVF is positive. So when that happens, remember that we said always look at lead 2 to kind of verify. And we see that lead 2 is actually negative as well. So in this case, we have a right axis deviation. And another thing that we can do to verify that in fact we had a right axis deviation, we look at the R wave progression in the anterior leads, right? And normally we expect the anterior leads to start negative and then start becoming more positive and positive as the wave of depolarization travels from V1 to V6. But in this case, we can see it starts positive and remains positive. So that also verifies that we have a right axis deviation. Again, if you need a refresher on axis, we also have a video on how to identify axis, and also gonna link that video in the description below for you, okay? So we have a right axis deviation, okay? Very good. Then T is for QT interval, and the way we assess for that is to make sure that the T wave is not more than 50% between QRS and QRS, and we find a T wave right here just to make it easier. So it's not more than 50% between QRS and QRS, so that's normal. So there's no QTC prolongation. Then I is for ischemic changes, and ischemic changes we see either Q wave, ST segment elevations, ST segment depression, or T wave inversions, right? And we also check in an anatomical way. So we start looking at the left lateral leads. So those are lead 1, AVL, V5, and V6. And there's no Q waves. There's no ST segment depression. There's no ST segment elevation, but there are some T wave inversions, right? So we can see some T wave inversions here in V5 and V6. However, in our video on axis, we also mentioned that for a T wave inversion to be consistent with ischemia, it has to be a symmetrical T wave. So it has to look something like this. That when you do a mirror image, it looks the same. When you divide it in half to be a mirror image, it look the same. However, in this case, we can see, and it's easier to see in V4, we have a downsloping and then an upstroke. In that video, we said that when we see that specific morphology, it's most likely due to a secondary repolarization abnormality, not due to ischemia. In this case, this secondary repolarization abnormality is due to right axis deviation, okay? Very good. All right, so that's the left lateral leads. Let's look at the inferior leads, and we look at lead 2, lead 3, AVF, same questions, Q waves, ST segment depressions, elevation, T wave inversions, and we see none of that here, okay? Very good. And then finally, we look at the anterior leads. V1 and V2 are usually called the septal leads, but they're part of the anterior leads. So we look at, let me change color, we look at V1 and V2, and we again see that downsloping and upstroke, downslope and upstroke. So those are secondary repolarization abnormality, not ischemia. and we see that throughout the whole precordial leads, V1 to V6, we see that T-wave inversion. So in this case, there's no ischemic changes. We should only see secondary repolarization abnormalities. Okay, and finally we assess chambers, and chambers we mean either left ventricular hypertrophy or right ventricular hypertrophy. So remember that for left ventricular hypertrophy, we have some criteria that we need to meet. We have the Lyons-Sokolow criteria, we have the Cornell criteria, which you can review in the ACCESS video as well, ACCESS, which is going to be linked in the description below. And in the case of right axis deviation, usually right axis deviation means right ventricular hypertrophy, but not necessarily, okay? So in here we can have potentially right ventricular hypertrophy, but we don't know for sure unless we actually do a echocardiogram. So possible right axial deviation, okay? I mean possible right ventricular hypertrophy. Okay, so we covered a lot. Let's summarize. So in this EKG, we have a third-degree AV block with an idioventricular escape rhythm with a rate of 24 beats per minute. We have right axis deviation with secondary repolarization abnormalities. And that's it, okay? So not too bad once you complete everything. If you narrow everything down in a systematic way, then it's going to be much easier to tackle any EKG regardless of how complicated it might seem, okay? All right, my friends, that's all for today. Next video, we're going to start talking about bundle branch blocks. So thank you for watching these videos, and as always, I'll see you at the Cardiac Academy.